Welcome back to the Deep Dive, where we take complex, critical source material and cut straight to the core of what you need to know.
Today, we are undertaking a deep dive into human resilience, specifically the physiological limits and clinical strategies for surviving environmental emergencies.
And this field of medicine, environmental emergency medicine, it feels like it's never been more relevant.
Oh, absolutely. We're seeing two massive trends converge globally. First, you have climate change, which is, unfortunately driving more frequent and severe extreme weather events. We're talking intense heat domes, dangerous cold snaps, massive flooding.
And the second trend is just globalization, isn't it?
It is. The ease of modern travel means that people are now routinely exposing themselves to environments their bodies are completely unprepared for.
Whether that's high-altitude trekking in the Andes or, say, diving in deep remote waters.
Exactly. And the professionals we are focusing on, expedition doctors, military medics, pre-hospital care teams, they face a unique and frankly daunting challenge.
They have to operate in these incredibly stressful conditions.
Often hours, sometimes days, away from definitive care. They're relying on minimal equipment and just maximum ingenuity.
So for you, the learner, listening today, our mission is to deliver 4 core pieces of knowledge. First, how the environment impacts normal physiology.
Then the intricate ways the body attempts to adapt or acclimatize.
How to recognize the most common and severe illnesses that result, and critically, the pragmatic management plans that can stabilize a patient until more sophisticated resources are available.
And that leads us straight to the fundamental difficulty of this kind of medicine.
Assessment.
Assessment in an austere setting. Our source material stressed that in remote or extreme environments, the standard physical examination becomes incredibly unreliable. Sometimes it's actively misleading.
Unpack that a little. Why is the classic physical exam, listening to the chest, checking pulses, why is that so difficult when you're out in the field?
Well, just think about the conditions for a second. If you were trying to examine someone in a high wind, you might completely miss subtle differences in breath sounds or, say, muffled heart sounds.
Okay, that makes sense.
Or if the patient is severely cold, peripheral vasoconstriction, that's the body shutting down blood flow to the extremities to conserve core heat, that can make the pulse impossible to feel.
And that would hide signs of blood loss too.
It hides everything. It skews your vital signs. And furthermore, in that intense cold, you might not be able to safely remove the patient's clothing, which is, a fundamental requirement of a good trauma exam.
It sounds like the environment itself becomes a barrier to diagnosis. So if we can't fully trust the physical exam, what takes its place? What's the most critical diagnostic tool?
Without question, a careful, detailed history. The source material emphasizes that history-taking is almost always more helpful for diagnosis than the examination, particularly in the field.
So you need the story.
You need the whole chronology of events. When did they start feeling sick? What was their ascent profile? What are they wearing? When did they last eat? What medications did they take? All of it. If circumstances prevent a full history immediately, it has to be the very first thing you complete once the patient is stable enough to talk.
That distinction, relying on the narrative over the physical signs, that's a crucial nugget for anyone practicing in these conditions.
It really is.
Okay, so let's look at the immediate response protocol. Most of us are drilled on the primary survey, the standard CABCD. How do we adapt that for an environmental emergency?
Well, the standard survey always begins with ensuring safety and assessing responsiveness. Then it moves into catastrophic hemorrhage, that's the first C. Then airway, breathing, circulation, and conscious level, or D.
But in environmental medicine, we add a critical step.
We add E, which stands for environment protection.
So before you even get to definitive care, you have to address the surrounding context.
Precisely. Before you try to fix the internal damage, you have to isolate the casualty from the external stressor. If they're hypothermic, you must insulate and shelter them immediately.
And if they're hyperthermic?
You have to remove them from the sun and start cooling. That E is completely non-negotiable. If you fail to protect the patient from the environment, all your subsequent medical interventions are, they're likely to fail.
That frames the entire problem perfectly. Now let's set the stakes for the rest of our deep dive. The sources include a list of the fatal conditions. It's box 16.1. It's a sobering reminder of the scope of catastrophic failures we were talking about.
It really covers the full spectrum of risk, doesn't it? We're discussing high-altitude cerebral edema, or HACE,
Drowning, severe hypothermia, heat stroke.
and then the mechanical damage of arterial gas embolism, and the incredibly rare but devastating high-stakes events like a lightning strike or acute radiation sickness.
What strikes me is the massive difference in prevalence among those conditions. Drowning, as the source notes, is a massive global health problem.
It's staggering, something like 1,000 deaths every single day worldwide.
And then on the other end of the spectrum, you have something like HACE, which, while utterly lethal, is relatively rare and, geographically isolated.
And that speaks to the discipline required. Practitioners have to be ready for the high-frequency, low-resource tragedy like drowning, but also maintain the high-acuity skill set for the rare, complex, high-technology-dependent crises, like managing a radiation victim or treating a severe decompression illness.
So the common thread is that every one of these conditions represents the body's fundamental systems being pushed past the point of no return.
Pushed past the brink by external forces, exactly.
All right, let's start our ascent with Section 1, the vertical challenge, focusing on aviation and high altitude. When we discuss aviation medicine, we are looking at a highly specialized field.
Oh, it is. It's truly holistic. Aviation medicine isn't just about patching up a passenger with a bug. It considers the health, the performance, and the safety of everyone involved in air or space travel.
So passengers, crew, pilots, controllers, the whole system.
The whole system. The objective is to proactively manage human physiological risk within a system designed for high speeds and high altitudes. It's where clinical care meets human factors engineering.
And what are the specific environmental elements that flying subjects us to?
The challenges are, well, they're extensive. Most prominently, we have reduced barometric pressure, which is the root cause of hypoxia and decompression sickness.
Right.
But we also deal with significant acceleration forces, increased radiation exposure, especially on polar routes, noise, vibration, thermal stress.
And the really debilitating issues like motion sickness and spatial disorientation that can really affect crew performance.
Exactly. And if we take that environment to the absolute extreme outside the atmosphere, in space, the primary challenge is microgravity, or weightlessness. This affects every single system of the body. Bones lose density at a shocking rate. The cardiovascular system is constantly trying to adjust to the lack of gravitational pressure, and muscles just atrophy.
So how do you fight that?
To counteract this systemic deconditioning, astronauts require really intensive countermeasures, primarily high-resistance and aerobic exercise regimens, simply to maintain functional muscle and bone mass during long-duration missions.
That gives us the big picture. Let's dial back to commercial air travel, which impacts millions of us. The concept of fitness to fly is vital for healthcare providers. What exact environmental stress are we placing on the body in a standard pressurized cabin?
Okay, so commercial aircraft are pressurized to an atmospheric pressure that's equivalent to an altitude of about 1,500 to 2,500 meters.
That's about 5,000 to 8,000 feet.
Right. And at this altitude, the partial pressure of inspired oxygen is lower than it is at sea level. So this induces a mild but manageable degree of hypoxia.
For a healthy passenger, this is barely noticeable, right?
We'd hardly feel it. But for those with underlying cardiorespiratory disease, that mild hypoxia could be the thing that tips them over the edge.
So patients with pre-existing compromise, say severe COPD, heart failure, significant anemia, that mild hypoxia could be dangerous for them.
Precisely. They often require supplemental oxygen just to maintain adequate tissue oxygenation during the flight. And this brings up a really crucial practical detail from the source material regarding specialized equipment.
You're talking about the rule for non-invasive ventilation equipment, like CPAP machines.
Yes. If a passenger needs continuous use of NIV or supplemental oxygen, they have to carry it. But the critical logistical point is that the battery supply must be capable of lasting 1.5 times the duration of the planned flight.
1.5 times. Why that specific number?
It's a mandatory safety buffer. It accounts for unexpected delays, diversions, or holding patterns where external power might not be available.
That 1.5 times rule is a fantastic, actionable nugget of knowledge. Beyond oxygen, what are the other common passenger considerations, especially for long-haul travel?
Well, the risk of deep vein thrombosis, or DVT, due to prolonged immobility is well known. We advise mobilization, hydration, and compression stockings for anyone at high risk.
And administratively, medication.
Administratively, travelers have to be meticulous about their medications. You need sufficient supplies for the trip, plus a buffer in case your luggage is delayed. And you need a comprehensive doctor's letter detailing all essential drugs, especially if those drugs are controlled substances that might cause issues at security checkpoints.
And we can't stress enough the necessity of comprehensive travel insurance.
It's the absolute financial lifeline in a crisis. Insurance has to explicitly cover overseas medical costs, which can run into the hundreds of thousands of dollars for complex issues.
And you have to make sure the policy covers pre-existing medical conditions, right?
Absolutely. And critically, the cost of an aeromedical escort or a repatriation team for the flight home. Failing to declare a pre-existing condition, no matter how minor it seems, often voids the entire policy in an emergency.
Let's move higher now, beyond cruising altitude, into the realm of true high altitude, where the environment becomes actively hostile. The three primary challenges are low partial pressure of gases, intense cold, and solar radiation. But let's focus on the gas kinetics first.
This is where we need to dispel a really common misconception. The concentration of oxygen in the atmosphere, the percentage, remains 21% from sea level right up through the troposphere.
So the problem is not that the air is thin in terms of concentration.
Not at all. The problem is the density of the air molecules itself. The true fundamental challenge is the rapid fall in barometric pressure.
Which is the weight of the air column above you.
Exactly. And as that weight decreases, there are simply fewer total gas molecules, including oxygen molecules, in each breath you inhale. This mechanically reduces the partial pressure of inspired oxygen, the PO2, and that causes severe tissue hypoxia.
To make that tangible, let's use the incredible data from the source, specifically regarding Mount Everest, 8,848 meters, which is pretty much the limit of human physiological endurance.
Right. At the summit, the barometric pressure is a staggering low of 34 kilopascals, which is just 253 millimeters of mercury. The research team that sampled arterial blood from acclimatized climbers near the summit in 2007 found an arterial partial pressure of oxygen, a PO2 of only 3.3 kpr.
Which is how many millimeters of mercury?
It's around 24.6 mmHg. To put that in perspective, the lowest partial pressure of oxygen found in critically ill patients at sea level who survive is usually still higher than that.
Wow.
The fact that the human body can even sustain consciousness, let alone effort, at that extreme edge demonstrates the profound power of acclimatization.
So acclimatization is the body's highly organized systemic effort to mitigate that tissue hypoxia. What is the immediate life-saving adaptation that kicks in?
The first most immediate response is increased ventilation. It's known as the hypoxic ventilatory response. You start breathing deeper and faster. This response is vital because it maximizes the available oxygen uptake, and simultaneously it blows off carbon dioxide.
Blowing off CO2, though, that throws the body's pH balance off, doesn't it? That makes the blood more alkaline.
It does, and this is where the kidneys step in to compensate. Over the first 24 to 48 hours, and continuing for about 6 to 8 days, the renal system starts compensating by increasing the excretion of bicarbonate in the urine.
So it induces a metabolic acidosis.
It does. It helps normalize the body's pH balance, making the increased ventilation more effective and sustainable long-term.
And what about in the cardiovascular system? What's happening there?
Initially, there's an increase in cardiac output. The heart pumps harder and faster to try to move more oxygenated blood around. However, as the other physiological processes stabilize, the cardiac output usually returns to near normal levels within a few days. The energy cost of pumping that hard for weeks on end is just too high.
The long-term adaptation is the one people most often cite. Increased blood cell count.
Yes, the hematopoietic system adaptation. This takes 2 to 3 weeks to really kick in. The body ramps up the production of red blood cells and hemoglobin, which increases the overall oxygen-carrying capacity of the blood.
But there's another adaptation that often gets overlooked, a chemical one.
Right, and it's critical for oxygen delivery. It's the role of 2003-diphosphoglycerate, or 2003-DPG.
Tell us exactly what 2003-DPG is doing at the molecular level to optimize oxygen delivery, not just carrying capacity.
So 2003-DPG is a molecule found in red blood cells. In high-altitude hypoxia, the concentration of 2003-DPG increases. Its function is to bind to hemoglobin and stabilize the deoxygenated form of the molecule.
What does that mean in practice?
What it does clinically is shift the oxygen dissociation curve to the right. This means that while the hemoglobin might not pick up oxygen quite as readily in the lungs, it releases it much more easily to the metabolically starving tissues, the muscle, and the brain.
Which is the ultimate goal of acclimatization.
Exactly. It's a physiological trade-off that favors tissue delivery over lung uptake.
That is fantastic detail. All these processes, they rely on time, which is why ascent protocols are the critical safety barrier. What is the fundamental non-negotiable rule for climbing above 3,000 meters?
The rate of ascent has to be strictly managed. Above 3,000 meters, you should ascend to a sleeping height of no more than 300 to 500 meters per day above the previous night's sleeping elevation.
And you can climb higher during the day.
Oh yeah, the climb high, sleep low principle is key. But you must always descend to that safe, slower sleeping altitude.
And what about rest days?
A rest day has to be factored in every 1,000 meters of cumulative ascent, or every 3 to 4 days, even if you feel fine. Pushing the body too fast violates the time required for those renal and hematopoietic systems to fully catch up.
If you push too fast, you enter the realm of altitude illnesses. Acute mountain sickness, AMS, HACE, and HAPE. Let's start with AMS, which is the most common.
AMS is a clinical syndrome. It's characterized by a headache plus one or more accompanying symptoms.
Like fatigue, nausea, poor sleep.
Exactly. It typically manifests 4 to 6 hours after arrival above 3,000 meters and affects about a quarter or more of unacclimatized travelers.
How do you differentiate mild AMS from something like simple dehydration or just a regular headache?
At altitude, the key clinical rule is, until proven otherwise, you have to assume the symptoms are altitude-related. If they're mild, treatment is rest, simple analgesia for the headache, and absolutely no further ascent. The symptoms should resolve within 24 to 36 hours.
But if they persist or get worse?
That is the immediate signal for mandatory descent, no questions asked.
What are the pharmacological tools we use for prevention or early management?
Acetazolamide is the gold standard for prophylaxis. Its mechanism is actually brilliant. It inhibits an enzyme called carbonic anhydrase, which forces the kidneys to excrete bicarbonate.
Inducing that mild, controlled metabolic acidosis we talked about.
Right. And the body responds to acidosis by increasing ventilation. It forces you to breathe deeper, thereby jump-starting the natural acclimatization process.
So acetazolamide actually facilitates acclimatization. What about dexamethasone?
Dexamethasone is also highly effective at reducing the symptoms of AMS and HACE, but critically, it works by reducing cerebral swelling and inflammation. It alleviates the discomfort and allows the patient to continue, but it does not accelerate the underlying physiological acclimatization.
So it's just masking the problem.
It masks the problem rather than fixing the root cause, which is why it's usually reserved for emergency use or when acetazolamide is contraindicated.
Now for the two life-threatening conditions, starting with high-altitude cerebral edema, or HACE. This is essentially altitude sickness progressing to brain swelling.
HACE is the culmination of severe altitude illness, often preceded by severe AMS. It represents massive cerebral dysfunction due to vascular leak and edema.
What are the key symptoms? How do you spot it?
The key symptoms are neurological, severe ataxia, that's the inability to walk a straight line or coordinate movement, and a significant change in the level of consciousness. This is an urgent, life-threatening emergency. Death is possible within hours.
What is the definitive intervention for HACE?
Immediate descent. It is non-negotiable, and it is the single most life-saving measure you can take. If available, you give oxygen and high-dose dexamethasone immediately to reduce the swelling. But physical descent has to be initiated at once.
And even if they recover?
Even if they recover, they can face a potentially worrying long-term prognosis, including chronic ataxia or cognitive impairment.
The other extreme, high-altitude pulmonary edema, HAPE, is a killer in the lungs.
HAPE is a life-threatening lung condition. It results from extreme pulmonary hypertension and fluid leakage into the lungs. Untreated, the mortality rate is catastrophically high, around 50%.
And when does it typically present?
Usually at 2 to 5 days after a rapid ascent. The signature features are breathlessness at rest, a significantly decreased exercise tolerance, and a persistent rapid breathing rate. The cough starts dry but progresses to produce frothy, often pink, sputum.
And again, descent is key.
Immediate rapid descent is the primary treatment. While you're preparing for descent, you administer oxygen if possible and vasodilators. Nifedipine and sildenafil have been shown to be acutely beneficial.
Because they reduce the pressure in the pulmonary circulation.
Exactly. They help stem the fluid leakage. Inhaled beta agonists can also help.
So what if immediate descent is impossible? You're on a remote ridgeline, there's a blizzard. The source mentions a fascinating piece of field technology. The portable hyperbaric chamber.
This is a brilliant temporary measure. It's essentially a large, airtight material bag. By using a foot pump, the rescuer can manually pressurize the bag, increasing the internal pressure by about 13.7 kPa above the ambient external pressure.
And why that specific number? 13.7 kPa.
Because that specific pressure increase simulates a rapid descent of about 900 to 1,200 meters.
It buys time.
It buys critical time. This temporary pressure change reverses the effects of hypoxia long enough for the medical team to stabilize the patient, administer medication, and execute a safer, more organized evacuation to a lower altitude. It's often the difference between life and death.
Finally, before we leave the vertical challenge, let's quickly look at the specific ocular injuries associated with high altitude, starting with solar keratitis.
Solar keratitis is widely known as snow blindness. It is a severe, painful corneal burn caused by exposure to intense UV light reflecting off snow and ice without adequate eye protection.
And the pain is debilitating.
So extreme it can incapacitate the victim. Although recovery is spontaneous in 2 to 3 days, strong analgesia is required during that period, and it is entirely preventable with proper sunglasses.
And what about the visually striking issue of retinal hemorrhage?
Small flame-shaped hemorrhages within the retinal nerve fiber layer are surprisingly common above 5,000 meters. They are usually asymptomatic and often resolve without intervention.
But rarely they can affect vision.
Rarely they occur over the macula, causing a painless, temporary loss of central vision. But even these typically recover fully once the individual descends.
From the challenge of thin, cold air, we now plunge into the core danger of the cold environment. Section 2 focuses on how the human body battles freezing temperatures. What is immediately striking here is the limited capacity for physiological adaptation compared to, say, heat.
That's absolutely true. Our core strategy against cold is, well, it's behavioral adaptation. It relies almost entirely on appropriate clothing, adequate calorie intake, and strategic sheltering.
And we lose heat through those four mechanisms.
The familiar four: conduction from direct contact, convection from moving air or water, radiation to colder objects nearby, and evaporation from sweat or wet clothing.
I want to pause on the most astounding fact in our source material, the survival statistic you noted. The lowest documented core body temperature from which an adult successfully recovered from accidental hypothermia with a good neurological outcome.
That T-core was an astonishing 13.7 degrees C.
13.7.
Yes, and this data point is crucial because it shows the profound level of neurological protection that deep, sustained cooling can provide, provided the cooling occurred before the circulatory collapse.
So the immediate implication for responders is,
You must never assume death based on vital signs alone in a cold environment.
let's define hypothermia. A fall in core body temperature, or T-core, to less than 35 degrees C. The body's immediate aggressive defense is shivering. We know it's effective, but what is its critical limitation?
Shivering is extremely effective. It's capable of raising the temperature by 3 to 4 degrees Celsius per hour. However, it requires massive energy reserves and is metabolically very demanding.
And at some point, it just stops.
Crucially, once the T-core drops below 30 degrees C, shivering ceases entirely. At that point, the patient has lost the ability to generate heat independently. They cannot rewarm without external intervention.
What about the internal metabolic slowdown, the brain?
The brain is the primary beneficiary of that slowdown. For every 1 degree Celsius drop in T-core, the brain's metabolic demand decreases by about 10%. If the cooling is fast, this reduced metabolic demand protects the brain tissue from permanent damage, allowing resuscitation to be prolonged far beyond what we would attempt at normal temperatures.
We tend to think of this as an expedition or mountain rescue problem, but the source highlights the commonality of urban hypothermia. What drives this often overlooked public health issue?
Urban hypothermia predominantly affects vulnerable groups: the frail, the elderly, those experiencing social deprivation. It's caused by a perfect storm of inadequate housing, lack of heating, poor nutrition, and chronic illness.
And the elderly are particularly at risk.
Yes, a specific vulnerability in the elderly is their diminished sense of cold, coupled with reduced insulating subcutaneous fat. so they often fail to take protective action until it is dangerously late. Neonates also cool very rapidly due to their high surface area to volume ratio.
In austere settings, cold water immersion is a rapid killer.
Cold water is just brutally efficient at stripping heat. Immersion in relatively mild water, we're talking 15 to 20 degrees C, can induce hypothermia after just 30 minutes.
And if the water is colder?
If the water temperature is below 12 degrees C, the danger is immediate. The limbs rapidly become numb, impairing nerve function and muscle strength, which leads to swim failure and subsequent drowning in minutes.
To guide the clinical response, the Swiss hypothermia staging is essential. Let's walk through the clinical presentation of the 4 stages, linking the core temperature to the patient's status.
Okay. Stage 1 is mild hypothermia, 35-32 degrees C. Here the patient is conscious, alert, and actively shivering. They can be treated passively in the field.
Stage 2 is moderate, so that's below 32 degrees C down to 28 degrees C.
At this stage, the patient's conscious level starts to decline. They become confused, drowsy, or lethargic. Critically, shivering may stop here, and the risk of cardiac complications starts to rise.
Stage 3 is severe, so we're below 28 degrees C now.
The patient is unconscious, unresponsive, but vital signs are still present, though they may be very difficult to detect. You need a full minute of checking for a pulse. Below 28 degrees C, the risk of ventricular fibrillation, VFib, rises significantly, and even gentle movement can precipitate this fatal arrhythmia.
And finally, stage 4 is apparent death, typically below 24 degrees C.
The patient is clinically inert. There are no discernible vital signs after a full 1-minute check. As we established, this is the stage where the not dead until warm and dead rule is most aggressively applied.
Okay, given that staging, let's compare field management. For stage 1, it's passive rewarming. What does that involve practically?
Passive rewarming involves maximizing the body's own natural heat generation while minimizing heat loss. You remove wet clothing, provide shelter, add multiple layers of dry insulation, and give warm sugared drinks for calories and morale.
What about those foil blankets?
Well, external foil blankets provide minimal rewarming power on their own. The peripheral vasoconstriction prevents heat from actually reaching the surface. Their main job is to stop further heat loss.
Once they hit stage 2 or 3, when shivering has stopped, the management has to become aggressive and focused entirely on transport.
Absolutely. They require urgent evacuation. They must be placed in a specialized hypothermia wrap. This is a multi-layer system that includes a crucial, non-negotiable vapor barrier.
And why is a vapor barrier so important?
It prevents heat loss via evaporation from perspiration or damp clothing inside the wrap. And movement, you have to handle them with the utmost gentleness to prevent VFib.
And stage 4, where the patient is in cardiac arrest or apparent death, requires the highest level of resource allocation.
Yes. These patients must receive standard CPR immediately and continuously. They must then be transported, even if the CPR is ongoing for hours, to a hospital equipped with extracorporeal cardiac life support, or ECLS, facilities.
And ECLS involve what kind of technology?
ECLS refers primarily to techniques like cardiac bypass or extracorporeal membrane oxygenation, ECMO. These machines take the patient's blood out of the body, warm it up, oxygenate it, and then pump it back in.
So it's the only reliable way to actively rewarm the core.
It's the only way to rewarm the core and the brain while simultaneously maintaining circulation during a cardiac arrest. It is incredibly resource-intensive and high-tech, which is why transport logistics are so vital.
That record recovery after 6.5 hours of CPR with a T-core of 23.2 degrees C really underscores the necessity of this sustained effort. How do clinicians decide whether to deploy ECLS when the prognosis is so uncertain?
There's a tool for that. The Hypothermia Outcome Prediction, or HAPE score, is a crucial clinical tool used in the hospital setting. This score integrates factors like the patient's potassium levels, the mechanism of injury, and the severity of the hypothermia to give clinicians an objective assessment of the probability of survival.
So it guides those difficult decisions about resource deployment.
It does.
Let's turn to avalanche medicine, which is a specific cold trauma scenario. When a person is buried under snow, what are the 2 distinct phases of death?
The first phase is immediate, occurring in the first few minutes. It's death from either asphyxia or massive trauma from the forces of the avalanche itself. Survival here hinges entirely on immediate rescue by unburied companions.
And the second phase?
The second phase, once buried, is progressive hypoxia, carbon dioxide buildup, or hypercapnia, and ultimately hypothermia. Survival declines dramatically after 10 to 15 minutes of burial due to that hypoxia.
This complexity means the warm and dead rule needs some refinement in this specific context. What is the crucial time point for management differentiation?
The 60-minute cutoff. If the patient is found in cardiac arrest within the first 60 minutes of burial, the primary cause of death is overwhelming asphyxia. In this case, standard CPR protocols apply, and outcomes are, unfortunately, generally poor.
But if they're found after 60 minutes?
If they are found in cardiac arrest after 60 minutes, it's assumed they were able to maintain some level of breathing, allowing them to become deeply hypothermic before the cardiac arrest occurred.
And in that scenario, the hypothermia may have protected the brain.
Exactly. And that demands continuous resuscitation and transfer for ECLS, regardless of how long the burial lasted.
Moving on to peripheral cold injury. We have two main types: non-freezing cold injury, NFCI, and frostbite. Let's start with NFCI, or trench foot.
NFCI is caused by prolonged exposure to wet and cold conditions where the tissue temperature remains above freezing. It was notoriously recognized in military campaigns. The pathology involves nerve and vascular damage without ice crystal formation.
And the long-term effects are bad.
Critically, the long-term sequelae are often extremely disabling. They can result in chronic cold sensitivity, pain, and hyperhidrosis that can last for years.
How does the injury progress clinically?
It moves through three distinct phases. First is the pre-hyperemic phase, which lasts hours to days. The foot is cold, pale, and swollen.
And then?
Second is the hyperemic phase, lasting about 10 days, where the foot becomes hot, red, and very painful, accompanied by sensory loss or burning and muscle weakness.
And finally?
The long-lasting post-hyperemic phase, characterized by that persistent cold sensitivity, chronic pain, and potential atrophy.
Now, true frostbite, where the tissue temperature actually drops below 0 degrees CD. What are the sequence of injury phases here?
Frostbite is far more complex than just simple freezing. It starts with the pre-freeze phase of cooling and severe vasoconstriction. Then, the freeze-thaw phase involves the formation of sharp ice crystals that mechanically rupture cell membranes,
Causing immediate cellular damage.
Yes, and critically, when the tissue thaws, it initiates a massive reperfusion injury, a huge inflammatory reaction leading to microvascular damage. This causes vascular stasis, sludging of blood, thrombosis, coagulation, and finally, late ischemic injury and tissue death.
The management hinges on one critical, counterintuitive field rule regarding rewarming.
Yes, and it is. Do not rewarm in the field if there is any possibility of refreezing.
Why is that so important?
Refreezing partially thawed tissue causes exponentially worse microvascular damage. It's a secondary catastrophic reperfusion injury. If evacuation is delayed and refreezing is a risk, the tissue should be kept frozen and protected from trauma until the patient can be transported to a safe, controlled environment.
And when rewarming is performed, what is the best technique?
Rewarming must only be done in a suitable hospital or controlled environment. You use a moving water bath maintained at a comfortable non-scalding temperature of 37 to 39 degrees C. This provides the most rapid, controlled, and least damaging thaw.
And what about surgical intervention for the obvious damage?
The rule is delay, delay, delay. Except in cases of life or limb-endangering infection, surgery, particularly amputation, should be delayed indefinitely.
Because the tissue can recover better than it looks.
Clinical experience shows that tissue salvage often dramatically exceeds initial clinical estimates of viability. Rushing to surgery results in the unnecessary loss of digits or limbs. Specialized hospital management might include medications like TPA or prostacyclin analogs to try and mitigate that inflammatory and thrombotic cascade.
We transition now to the reverse thermal extreme, where the body is struggling to dump heat. Our core body temperature is tightly regulated at 37 degrees C by the hypothalamus, which acts like a thermostat. What is the principal mechanism the body relies on for heat loss, especially during exertion?
The vast majority of heat loss, particularly during exercise in a hot environment, occurs via sweat evaporation. It's incredibly efficient. We also lose heat via conduction, convection, radiation, and expiration.
But evaporation becomes critical when it's really hot out.
Yes, when the environmental temperature exceeds the skin temperature, the body can't lose heat via radiation or conduction. Evaporation is the only route left.
Which demographic groups are most vulnerable to heat illness, especially as heat waves become more common?
The elderly and those with chronic diseases are at the highest risk. Their thermoregulatory capacity is diminished due to factors like reduced sweat gland function, decreased cardiovascular reserve, and often medication use that interferes with temperature regulation. This vulnerability is why heat waves globally have become a major driver of excess mortality.
We talked about acclimatization to the cold being limited. How effective is the body at acclimatizing to heat?
The body is much better at adapting to heat, but it takes time, several weeks, and it requires controlled exposure and workload management.
What are the key adaptations during this period?
They're twofold. First, the total volume of sweat produced increases substantially, which maximizes your evaporative cooling capacity. Second, and critically, the salt content of that sweat decreases, allowing the body to conserve essential electrolytes. This improves thermal stability.
Let's review the spectrum of exertional heat illness, starting with the mildest, like prickly heat rash and heat cramps.
Prickly heat, or miliaria rubra, is just an itchy red rash caused by the blocking or damage of the sweat ducts, which impairs sweat release. Management is simple: cool showers, loose clothing, talcum powder.
And heat cramps.
Heat cramps, conversely, are painful muscle spasms, often hitting fit individuals exercising intensely in the heat.
There's a fascinating debate over the cause of heat cramps. What are the competing theories?
Well, traditionally, we blame the cramps on simple electrolyte imbalance and dehydration. We assumed sodium loss through massive sweating was the culprit.
But that's not the whole story.
More recent sports medicine research strongly supports a theory of altered neuromuscular control. This suggests that fatigue combined with high ambient temperature increases muscle spindle activity and alters nerve conduction, leading to uncontrolled contractions.
So the treatment focuses on the neuromuscular side.
Exactly. It focuses on stretching, massage, and gentle rehydration, favoring that neuromuscular theory.
Next, heat syncope, a temporary loss of consciousness.
Heat syncope is driven by the body's attempt to shed heat. The blood vessels near the skin undergo massive peripheral vasodilatation. While that's effective for cooling, it significantly reduces the central venous return to the heart.
So when you stand up,
When the person stands up or exerts themselves, the transient drop in blood pressure causes syncope. It resolves completely with rest in the supine position and rehydration.
heat exhaustion is a moderate illness, the red flag that precedes catastrophe.
Heat exhaustion results from prolonged exposure or strenuous exercise, sometimes exacerbated by protective or insulating clothing like military gear or certain sports uniforms.
Now go to the symptoms.
They're systemic. Profuse sweating, weakness, dizziness, nausea, and vomiting. The T-core can be normal or moderately elevated, but typically it's below 40 degrees C.
Management here is all about stopping the process before it escalates.
Absolutely. The patient has to be removed from the hot environment immediately. Cooling measures should start sponging, fanning. Oral rehydration is usually sufficient, but if nausea and vomiting are severe, intravenous fluids are necessary. If heat exhaustion is left untreated, it is the direct precursor to heat stroke.
Heat stroke. This is the acute, life-threatening emergency where T-core usually exceeds 40 degrees C. The stakes are immense, and they're tied directly to the duration of the high temperature. What is the single most important diagnostic feature?
It is the presence of neurological dysfunction. This is the non-negotiable diagnostic criterion. It can manifest as confusion, delirium, seizures, or a coma.
And what about sweating?
Well, while the skin is often intensely hot and dry, it is vital to remember the clinical caveat. Sweating is not invariably absent. You can have a patient presenting with heat stroke who is still sweating profusely. You have to focus on the neurological status, not the skin moisture.
Given that morbidity and mortality are directly correlated with the time spent above 40 degrees C, the priority is clear.
Immediate, rapid core temperature reduction. We have to drop the T-core below 40.5 degrees C as urgently as possible. The most effective method, if it's available, is cold water immersion, as it maximizes conductive and convective heat loss.
And if that's not available,
Use ice packs over major blood vessels neck, armpits, groin, aggressive fanning, and continuous sponging.
and unlike conditions like fever, where pharmacological agents might help, the approach to heat stroke is entirely physical.
Correct. No pharmacological agents like paracetamol or NSAIDs are effective in lowering core temperature in heat stroke. The mechanism is a failure of thermoregulation, not a reset of the hypothalamic thermostat due to infection.
Finally, a specific complication for endurance athletes in the heat: hyponatremia. This seems counterintuitive in what is essentially a dehydration crisis.
It is a critical distinction. Hyponatremia occurs when endurance athletes, often marathon runners, overhydrate with excessive amounts of plain water or hypotonic fluids in hot climates. This just dilutes their blood sodium levels.
And there are hormonal factors at play too.
Yes, arginine vasopressin promotes fluid retention, and sodium is actively lost via natriuretic peptide mechanisms.
What are the symptoms of this low blood sodium?
Symptoms start subtly: headache, nausea, but can rapidly progress to life-threatening cerebral edema, confusion, fitting, and encephalopathy. The key preventive advice for athletes is simple but often ignored. drink to thirst, rather than trying to adhere to a rigid preset hydration schedule that assumes massive fluid replacement is necessary.
Moving to the water environment, Section 4. This covers everything from simple drowning to the complex physics of diving illness. Let's return to cold water immersion, which we categorized into 3 phases. The first 90 seconds are the most lethal.
That's the cold shock response. It's mediated by the sudden, overwhelming stimulation of cold receptors in the skin. This triggers a massive sympathetic surge, leading to an involuntary gasping reflex and the total loss of voluntary breathing control.
And the consequence of that involuntary gasp.
Many victims inhale a significant volume of water. We're talking 1.5 to 3 liters during this short, violent phase. They die almost immediately from asphyxiation. The critical advice, which is counterintuitive, is float to survive.
So you fight the impulse to gasp and flail.
You have to. You focus on remaining still to regain breathing control, which usually happens after about 90 seconds.
If they survive the cold shock, phase 2 is about 20 to 30 minutes later.
That's the peripheral cooling phase. The superficial nerves and muscles of the limbs cool rapidly. This causes a progressive loss of muscle dexterity, fine motor skills, and ultimately strength. Even strong swimmers experience total swim failure in this window because their limbs simply cease to obey commands.
And phase 3 brings us back to core temperature drop and ventricular fibrillation risk.
After about 30 minutes, the core temperature begins to fall, leading to disorientation, decreased consciousness, and eventually that high risk of ventricular fibrillation once the T-core drops below 28 degrees C.
Let's focus on drowning, which is defined as respiratory impairment from submersion in a liquid. Despite the dangers of cold water, the majority of global drowning deaths are due to asphyxia, not hypothermia.
That is the tragic reality. Most people are pulled from the water after a hypoxic arrest, and the brain has already suffered irreversible damage. Resuscitation attempts for hypoxic arrest are generally considered unlikely to succeed after 10 minutes of submersion.
And successes haven't been recorded after 20 minutes in normal temperature drowning.
That's right. This is where the hypothermic paradox offers a slim chance of extended survival.
And the paradox only applies if.
It only applies if the brain cools rapidly, usually below 30 degrees C before cardiac arrest occurs. This rapid cooling provides the metabolic protection we discussed earlier, significantly improving the hypoxic survival time.
Tell us again about the record recovery that highlights this paradox.
The most dramatic recorded case is a 7-year-old child who was immersed in icy water for 83 minutes. Their T-core was 13.8 degrees C.
And they recovered fully.
Due to rapid cooling and subsequent aggressive ECLS-supported rewarming, the child achieved a full neurological recovery. This just reinforces the need for sustained resuscitation in cases of known or suspected hypothermic drowning.
Now, a key safety point for rescue teams. Circumrescue collapse. What is the physiological mechanism behind this post-rescue fatality?
Around 20% of rescued victims die immediately upon or just after being pulled from the water. Cold water immersion causes intense peripheral vasoconstriction, which leads to a temporary increase in central blood volume.
So when the victim is suddenly lifted vertically from the water?
Gravity pulls the blood back down, the peripheral vessels suddenly dilate, and this results in acute relative hypovolemia. It's a sudden collapse in central venous return and subsequent cardiac arrest.
So the rescue technique itself can be fatal if performed incorrectly.
Yes. The crucial rule is that victims of cold water immersion must be lifted horizontally into the rescue craft or helicopter. They have to be kept in an orientation that actively assists venous return, minimizing that gravitational blood pressure drop.
Moving to diving emergencies, where the gas laws dictate the risks. We rely on Boyle's law, which governs how gas volume changes with pressure.
Boyle's law states that gas volume varies inversely with pressure. When a diver descends, the increasing pressure compresses gas-filled spaces in the body. If the diver fails to equalize the pressure in the middle ear, sinuses, or lungs, that pressure difference causes barotrauma.
What are the common symptoms of barotrauma?
The most common is middle ear pain or ear squeeze, which can progress to a ruptured eardrum. More severely, injury to the inner ear causes intense vertigo, often called the stagger's nausea, and deafness. Pulmonary barotrauma is also possible, leading to a collapsed lung.
And the most dangerous form of barotrauma, which is the second leading cause of death in sports diving.
Arterial gas embolism, or HE. This accounts for about 30% of diving fatalities. It happens when a sudden change in pressure, often from breath holding on ascent forces, gas bubbles across the delicate alveolar capillary membrane into the pulmonary circulation.
And those bubbles then travel.
They travel and embolize, or block, small arteries, primarily in the coronary circulation, causing cardiac symptoms, or, catastrophically, the cerebral arteries, leading to signs that mimic an acute stroke.
The other major danger is decompression illness, DCI, famously known as the bends. This is not about gas compression, but dissolved gas coming out of solution.
Correct. When a diver is at depth, inert gases like nitrogen and helium dissolve into the body's tissues in proportion to the ambient pressure. If the ascent is too rapid, these gases come out of solution too quickly and form bubbles,
And they form bubbles in the tissues.
particularly in the tissues surrounding the joints, the spinal cord, and the skin. This triggers an inflammatory cascade, thrombosis, and localized ischemia.
DCI is uncommon, around 2.8 cases per 10,000 dives, but how is it classified clinically?
We use type I and type 2. Type I is milder. It affects the musculoskeletal system and skin. Symptoms include joint and limb pain, often described as a deep, aching toothache, and that classic patchy, mottled rash known as cutis marmorata.
And type 2?
Type 2 is far more severe. It involves the central nervous system, spinal cord, and respiratory system. It can lead to paralysis, sensory changes, breathlessness, or seizures.
What is a major post-dive risk that divers often ignore?
Air travel. If a diver flies within 24 hours of diving, the further reduction in atmospheric pressure in the airplane cabin can act as a secondary uncontrolled decompression event and provoke DCI. It's absolutely essential to avoid flight after diving.
Treatment for both AG and DCI requires specific technology.
Yes, initial management is basic life support, administering 100% oxygen, lying the patient flat, ensuring hydration. But the definitive treatment is emergency recompression therapy in a hyperbaric chamber, following standardized pressure tables.
And the goal is to get those bubbles back into solution.
Exactly. You rapidly increase the pressure to force the problematic gas bubbles back into solution, allowing them to be slowly eliminated via the lungs under controlled conditions.
Finally, two other gas-related risks: nitrogen narcosis and oxygen toxicity.
Nitrogen narcosis occurs below 30 meters. At high partial pressures, nitrogen acts like an anesthetic, causing euphoria, loss of coordination, impaired judgment, the famous rapture of the deep.
And it's dangerous because it compromises decision-making.
It does, but it resolves completely and immediately upon ascent. Technical divers avoid it by using less narcotic gases like helium and oxygen mixes.
And oxygen toxicity.
This risk arises when divers breathe oxygen at high partial pressures for extended periods. The oxygen becomes toxic to the central nervous system and the lungs. On standard air, the toxicity threshold is deep, around 66 meters, but it can manifest as visual problems, confusion, muscle twitching, and ultimately, convulsions.
We wrap up our deep dive by looking at the physical world hazards, often catastrophic, always high stakes, starting with ionizing radiation, which comes from natural, industrial, and catastrophic sources.
The sources range from naturally occurring radon gas, which contributes to natural background radiation, to high-dose sources used in medicine and industry, and, most acutely, catastrophic releases from events like Chernobyl, Fukushima, or nuclear incidents.
From a clinical pathology standpoint, how exactly does ionizing radiation cause injury at the cellular level?
Ionizing radiation is high-energy, short-wavelength radiation that causes direct physical damage, primarily to DNA. This DNA damage prevents cellular replication and triggers programmed cell death, or apoptosis.
So the tissues with the highest rate of cellular division are the most sensitive.
Exactly. Which means the body systems that are the most vulnerable targets are the hematopoietic system, the blood-forming cells in the bone marrow, and the gastrointestinal tract with its rapidly dividing cells in the villus lining. This determines the specific syndromes we see.
The unit of absorbed dose is the gray, or G. How do we quantify lethality?
The dose is measured in gray, where 1 G equals 1 joule per kilogram. The lethal dose 50, or LD50, the dose that kills half of those exposed, assuming they receive aggressive supportive medical care, is around 4.5 G.
And the maximal survivable dose?
Even with the best medical care available, it's considered to be around 10 G.
Now, we have to address the critical distinction you raised earlier, which is the most important piece of information for first responders: the difference between being irradiated and being contaminated.
This is fundamental to scene safety and subsequent care. An individual who has simply been exposed to a source of ionizing radiation, an irradiated person, is like a flashlight that was on but is now off. They pose no hazard to others.
But a contaminated person is different.
A contaminated person has radioactive material physically on their skin, clothing, or hair, or it's been inhaled internally. That material is actively emitting radiation and poses a physical risk to everyone nearby.
So what does the responder protocol look like for a potentially contaminated patient?
If contamination is suspected, responders must immediately implement universal precautions, often including respiratory protection if particulate contamination is airborne. The patient's clothing has to be removed, as clothing can stop up to 90% of contamination, and then the skin must be repeatedly washed with soap and water.
And all that material is now hazardous waste.
All clothing and wash water must be carefully collected, labeled, and treated as radioactive waste.
And crucially, should this decontamination process delay life-saving trauma care?
Absolutely not. The treatment of life-threatening injuries or illnesses must proceed without delay. You stabilize first, then decontaminate if possible, but you do not sacrifice a life to achieve perfect decontamination.
Let's detail the 4 primary forms of acute radiation sickness, or ARS, which vary based on the dose absorbed, starting with the mildest dose, around 1 G.
This causes initial mild ARS, transient nausea, vomiting, and general malaise. Clinically, the first sign is often profound lymphopenia, a drop in lymphocyte count within a few days.
Moving up to the 2 to 10 G range, we see the life-threatening hematopoietic syndrome.
This is the failure of the bone marrow. The patient experiences initial transient vomiting, followed by a period of deceptive improvement. The critical failure occurs 2 to 3 weeks later. The bone marrow fails to produce new granulocytes and platelets.
Which leads to high mortality.
Yes, driven by overwhelming infections from a lack of white blood cells and uncontrollable bleeding from a lack of platelets.
Doses higher than 6 G lead to the gastrointestinal syndrome.
This involves vomiting within hours, followed days later by intractable bloody diarrhea and abdominal pain. The radiation strips the villus lining of the entire intestine, which leads to massive fluid and electrolyte loss, severe dehydration, and secondary infection because the gut barrier is destroyed.
And finally, the highest dose, above 30 G, causes the CNS syndrome.
This is a rapidly fatal syndrome. Symptoms include rapid onset of severe nausea, vomiting, disorientation, and confusion. Death usually occurs within 36 hours, driven by cerebral edema and cardiovascular collapse.
Management across all these syndromes is largely supportive, right?
Entirely supportive. Treatment focuses on meticulous control of infection with broad-spectrum antibiotics, management of hemorrhage with blood product transfusions, and aggressive fluid and electrolyte replacement. For the hematopoietic failure, growth factors can sometimes stimulate bone marrow recovery, but ultimately success is determined by the initial dose.
We transition dramatically now to lightning strike, a natural electrical hazard of immense raw power.
We are talking about exposure to more than 10 million volts of high-voltage direct current delivered over milliseconds. While only about 1 in 10 strikes is fatal, the energy is catastrophic.
What's the primary risk?
The primary risk is to the cardiac and respiratory centers.
What happens physiologically in a fatal strike?
The electrical discharge often causes immediate cardiac dysrhythmias, typically a systole or complete cardiac standstill. It also causes respiratory muscle paralysis, which can persist for a long time.
And there's blunt trauma.
The immense force of the strike often throws the victim, leading to significant blunt trauma, including fractures and internal injuries.
There is a distinctive skin pattern associated with lightning that often causes confusion.
The fern-shaped or feathering patterns, they're called Lichtenberg figures. They're caused by the electrical discharge tracking across the skin, but they are non-thermal phenomena and should not be mistaken for actual burns. They require no specific treatment.
Management relies on immediate action.
Scene safety, of course, is first you have to ensure the storm has passed, then immediate bystander CPR for cardiac arrest. Crucially, even if the heart restarts, that respiratory muscle paralysis may persist for a significant amount of time, sometimes hours, requiring sustained respiratory support until the nerve function recovers.
Contrast that high-voltage DC lightning strike with man-made electric shock, which is typically alternating current, or AC.
The source notes that AC current is generally considered more dangerous than a similar voltage DC current. Minor domestic shocks are painful but rarely life-threatening. They cause a brief, non-seizure muscle jerk and perhaps a small localized burn.
But serious effects are seen in industrial settings.
Yes. Serious effects, particularly with high-voltage industrial exposure, include ventricular fibrillation, severe muscular contraction that can hold the victim to the source, and profound electrical burns. And electrical burns are deceptive. The external burn may look small, but the internal damage from the electrical path can cause extensive deep muscle necrosis and even spinal cord damage.
We have completed a comprehensive journey today, traversing the edge of human physiological tolerance. From the extreme hypoxia of Everest to the freezing depths of stage 4 hyperthermia and the instantaneous power of electrical and radiation hazards.
It truly showcases the body's remarkable machinery, doesn't it? We saw the intricate mechanisms of long-term acclimatization, the kidneys balancing pH, the blood cells trading oxygen affinity for tissue delivery. But we also saw how swiftly that resilience fails when those limits are violently exceeded.
Resulting in these acute, life-threatening syndromes.
Exactly.
If we synthesize the management strategies across all these diverse extreme scenarios, what are the universal tenets that define environmental emergency medicine?
I think there are 4 core threads. First, scene safety always prioritize the rescuer. Second, the absolute primary importance of a rapid, detailed history, especially when the physical examination is so unreliable.
Code.
Third, urgent environmental reversal. That means immediate physical descent for HACE, rapid aggressive cooling for heat stroke, and continuous sustained rewarming for severe hypothermia.
And finally, the consistent reliance on highly specialized, resource-intensive interventions for the most critical patients.
Exactly. Survival in the most severe cases often hinges on technologies like hyperbaric recompression chambers for diving illness, or the high-tech, multi-hour support provided by extracorporeal cardiac life support, ECLS, for severe thermal crises.
Or the support of critical care needed for systemic failure in radiation sickness.
Yeah.
That reliance on high-tech resources brings us back to our final provocative thought for you, the learner. We noted right at the beginning that climate change is sadly exposing large populations, often in deprived communities with limited infrastructure, to increasingly frequent and severe environmental extremes: heat, cold, and flooding.
So considering the gold standard management for severe cases, which, as we have detailed, demands highly specialized, expensive, complex facilities like ECLS, ECMO, or sustained intensive supportive care, what will be the global health implication for these vulnerable communities lacking those resources as environmental emergencies escalate?
It encourages us to think about how this cutting-edge knowledge is applied globally and on a societal scale. Thank you for taking this crucial deep dive into surviving the extremes with us.
Thank you.
We'll catch you next time.